Okay, I'm going to go ahead and get started, and I want to welcome everyone to joining us today. Good afternoon. Welcome to today's Chronic Care Policy Alliance, or CCPA as we call ourselves, webinar on the 340B drug pricing program, helping patients or padding profits. It's been a very interesting discussion that we're going to have today. Thank you all for joining us. My name is Liz Helms. I'm the founder and CEO of this Chronic Care Policy Alliance, or CCPA, and also the California Chronic Care Coalition. So we are broadcasting out here from California. So we've got the East, the West, and the middle of the US all joining us today. Today's webinar will cover how the 340B program has strayed from its original intent, impacts patient across access to care, and opportunities for reform. I'm pleased to be joined by experts in the healthcare policy and patient advocacy fields who will educate our audience on the 340B program. We are joined today by Dr. Bill Smith, Senior Fellow and Director of the Life Sciences Initiative at Pioneer Institute. We are also joined by Jen Laws, the President and CEO of the Community Access National Network, or CANN. I am also pleased to be joined by the Reverend Kimberly Williams, the Executive Director of Choose Healthy Life. And lastly, but definitely not least, we will be hearing from Darbin Wofford, Deputy Director of Healthcare at Third Way. I want to thank you and thank all our panelists for taking the time out of their schedules to participate in today's webinar. Each one of your organizations have been involved in the discussions about the 340B program, and we're grateful to you for sharing your perspectives with us. I want to just give you a little bit of background for those who don't know who the Chronic Care Policy Alliance is. We're a network of state and regional healthcare advocacy organizations advancing public policy that improves the lives of those living with chronic conditions and diseases. And we have our core principles: prevention, affordability, access to care, and quality healthcare that resonate, I think, pretty much with everybody that we work with that are on this call today. We started working in the region on the West, and we've branched out across the US now. And so we have, we just actually finished our Forecast 25, where we had multiple states join us in Ohio talking about priorities for each of our groups. And 340B was one of the main issues that we talked about. For a long time, CCPA and the California Chronic Care Coalition have been active around the issue of the 340B program, advocating at the federal and state levels, creating educational resources and educating policymakers and patient communities about the program, which can be at times very confusing. We know that 340B was created by Congress with the intention to make prescription medications and healthcare services affordable for uninsured and low-income patients. But over the past 30 years, the program has seen significant growth and loopholes in the original statute that have been exposed and exploited. Now we must ask the question: is the program truly benefiting patients as intended? That's what we're going to dig into during today's conversation. And we hope that you'll find the presentations from our panelists informative. Just a few reminders, a little housekeeping. Before we begin our official program, I'll share just a few friendly reminders for our live audience. Throughout this webinar, please feel free to enter your questions in the Q&A box. Questions were also submitted during the registration process, and as time permits, I will incorporate them into our Q&A session. We will do our best to answer as many questions as possible, and I'm sure there's going to be plenty of them today. We will also be sharing resources in the chat throughout our panelist presentation to help you learn more about the 340B and dive deeper into the perspectives you'll hear today. Thank you all again for being here. And with that, let's get started. Our first presenter today is Bill Smith of the Pioneer Institute, who will set the stage on the issue of 340B, discuss the current state policy landscape, and highlight some educational resources to help individuals learn more about how 340B impacts their community. Thank you for being here, Bill, and I'll turn it over to you now.
Liz, thank you for the kind introduction, and thanks to CCPA for the invitation. I'm going to try to set the baseline and have a common sense explanation about where the 340B program came from, how it works, and where I believe the incentives have led the program to stray away from its original mission. So where did it come from? The original the program has its roots in the 70s and 80s. And in the 70s and 80s, there were a lot of uninsured folks, a lot of uninsured patients. Medicaid was a very small program at the time compared with it now. And so safety net institutions were forced to eat the costs of treating the uninsured. And many of them were struggling financially. So the pharmaceutical industry stepped in and started giving deep discounts to certain safety net hospitals on a voluntary basis, a purely voluntary basis. The hospitals understandably were concerned that someday those voluntary discounts would be withdrawn. So they went to Congress, and in 1992, they required those discounts. And the discounts are pretty significant. A recent Senate report came out and said the discounts are average about 53% off of list prices. So how does the program work? How does it generate money for hospitals? The hospitals can buy drugs at a very steep discount and then potentially sell them to patients who have Medicare or commercial insurance at a much higher rate. So they're doing what's called arbitrage on Wall Street. They're buying low and selling high. What does that mean in practice? So the average new oncology drug has a list price of about $200,000. And if the 340B discount is 53%, that means the hospital can buy that $200,000 drug for only $94,000. And if they can get a patient to come in who has commercial insurance or Medicare, who has good, strong insurance, they can potentially bill that insurance company for close to $200,000, which means if they bought it at $94,000, they're pocketing a spread of at least $100,000 on that one prescription. So that's how it generates funds for hospitals and clinics. But this ability to arbitrage the discounts has created some perverse incentives in the program. And let me just mention two. First, the 340B hospital only secures revenue from patients with very good insurance. There's an incentive to treat patients with good insurance. And this has caused some hospitals, but not all, some hospitals to locate their physician offices or to purchase physician offices and pharmacies, contract pharmacies in upper income areas designed to bring in patients with strong insurance. So a program that was designed to supposedly help the uninsured and low income is trending towards helping wealthier patients. And second, the ability to arbitrage the discounts creates a perverse incentive to drive up costs. Why is that? Why does it drive up costs? Because hospitals make more money when they buy expensive drugs. They can pocket more of the spread when they buy expensive drugs. So there have been studies that have shown 340B hospitals tend to use more expensive drugs than regular hospitals. And so employers who are providing health insurance to their employees and they're treated in a 340B facility are going to end up paying more for the cost of the health care for their employee and probably end up paying higher premiums. And taxpayers are overpaying for Medicare drugs. There's just no doubt about that, because the hospital is able to purchase the drug at a much lower cost and pass that discount and get reimbursed at a much higher rate. Finally, let me close by pointing out that the 340B program does not require hospitals to pass on discounts to patients at the pharmacy counter. So uninsured patients can pay full price. Studies have also shown that the federally qualified health centers, that is the clinics, are much more likely to pass on discounted drugs at the pharmacy counter to their patients, but only a minority of 340B hospitals pass on their discounts. So thank you for your attention, and I'm happy to take questions at the appropriate time. And thank you again, Liz.
Thank you, Bill. Alarming and informative. A lot happening in the 340B space that people don't even understand. And in many times, patients don't even understand that they are in a 340B facility. I'm going to hold questions until the end, and then we'll go through our questions and work with our chat. As you see things coming up in the chat box, and then be sure to put your questions in the Q&A. So thank you again, Bill, for that very informative overview. Next, we're going to hear from Jen Laws of CANN for a discussion about how the 340B impacts different patient populations and variations between covered entities within the program, as well as the importance of advocacy with a focus on efforts at the federal level. So Jen, I'm going to turn it on over to you. Welcome.
Thank you so much, Liz. Hi, everybody. My name is Jen Laws. I'm President and CEO of Community Access National Network. We're a 28-year-old national patient advocacy organization focused on HIV, hepatitis C, and substance use disorder from the patient perspective. And so we've done a fair amount of federal and state advocacy, both on issues like 340B and public health programs. And there's this intersection, right? 340B is a funding backbone for public health, particularly as it relates to the Ryan White CARE Act and for federally qualified health centers, for example. And those are really kind of the true definition of safety net situations, right? The 330 grant for federally qualified health centers states that entity must be willing to provide services regardless of ability to pay. That doesn't mean free, but it does mean regardless of ability to pay. Similarly, with the Ryan White program, it's specified to people living with HIV, but it's for low-income folks that couldn't, especially at the time that it was passed, get any kind of care services. And so very kind of narrow. We also see other grantee entities named in the 340B statute, like children cancer centers, rural hospitals are now an opportunity there, Soul community clinics, Soul community hospitals, and so on and so forth, Black lung clinics. There's these specialized populations that were aimed at receiving the benefit of this program. And when DISH hospitals got their little carbon and expanded under the Affordable Care Act because of Medicaid expansion, a lot more entities qualified. And so you're dealing with grantees who have their 340B revenue, which is currently monitored under HRSA. That might be changing a little bit here soon, and answerable for how they use their 340B revenue for those patient populations under that grant and reinvestment into those delineated activities associated with that grant. And then you have DISH hospitals that have no requirements around how 340B dollars are used. And so that creates a lack of oversight. In every other situation that we have a public health program of some kind, it's Medicaid, any kind of public benefit program, including direct cash benefits, things dealing with substance use disorder, housing, we have some kind of oversight. There's a mechanism of reporting where the government's actively involved. And HRSA just doesn't really have the capacity to be dealing with thousands of hospital systems with even more sites of access in which they're kind of drawing these 340B revenues. So the special populations that we see, like with Ryan White, really kind of live up to the highest ideals of the 340B program, right? That first piece, it says stretch scarce federal resources to serve more eligible patients, right? That is the first piece of intent. And that's part of what happens in the Ryan White space as a special population, particularly under the AIDS Drug Assistance Program. So the AIDS Drug Assistance Program provides no cost to patient antiretroviral medications, which stop chains of transmission of HIV, like reducing the number of HIV transmissions that we see, especially for these community populations of low income and high effect. So that's that's a big deal, right? That is measurable. That's an outcome we can put our fingers on. We can see it in surveillance reports. We know where that positive outcome is occurring, right? And we see some of that in expanded services for brown white clinics or FQACs, where those communities are seeing very direct benefit. There are some bad actors in that space, and that's one of the things that we're kind of concerned about is hospital entities or private entities kind of usurping that grantee role. So there's these really kind of excellent examples about how 340B works the way it should, versus how 340B is working in a way that kind of harms patient access to care through encouraging consolidation in hospital systems, contract pharmacies, and where we're seeing that historical consolidation is really kind of the biggest issue for us, is that it is away from communities of need. It's outside of rural communities. It's closing down access points, like actual physical buildings inside of Black impoverished communities, and we're seeing that in hospital. There's it's called something called a certification of public advantage that has to be filed when a hospital consumes another hospital system. It's where the state says we have responsibility to make sure that the public is going to continue to have an advantage in this situation. And in each of those filings, we see that 340B is one of the primary and driving factors for hospitals to consume one another. And states aren't doing a good job of making sure that consolidation doesn't further occur as a result. So there are these opportunities that we have as patients to say, hey, we know how 340B should work to further issues around health equity, right? To reduce health disparities. We know what happens when people have access to direct discount medications. They stay more adherent to their medication. They are more productive members of society, however you want to frame that. We stop chains of transmission when it comes to infectious diseases. We improve people's lives. And that's really kind of an important focus not to lose sight of, especially as this is not necessarily a direct benefit as we typically see with the AIDS drug assistance program. It's a pass-through through these entities that are supposed to be doing the right thing. And supposed to be the critical part here, because again, HRSA doesn't have the opportunity for oversight the way that they should. And the requirements around that really kind of end up being kind of weak. There's issues and concerns around what is the allowed use for these dollars, and I think that can get fuzzy. I think it's much easier to define disallowed use, right? Don't buy up physician practices around you. Don't use this to pad your executive compensation. Don't use this to buy out a transfusion center 30 miles away just so you can build another cancer center in this suburban neighborhood that's already got 3, right? So there are things that we can kind of put our fingers on as patients to say this is what 340B should be doing. And in the historical HIV space, and this is why patient advocacy is really kind of important. We have the Denver Principles, right? And the Denver Principles outline this phrase that we see over and over and over again. It's nothing about us without us, right? You're not going to end up with a solution to problems that serve patient need and patient interest and reduce things like medical debt and increase access to care and increase patient adherence if patients aren't driving those solutions, right? Aren't focused on, aren't identifying the problems and the solutions to those problems. And that's part of why patient advocacy around this issue is kind of important. CANN is focused on educating patients across multiple states and helping them kind of hone the issues that are important within their communities and how to approach their legislators intelligently with knowledge behind the federal reform issues and efforts that we're seeing with things that can improve how 340B operates to the benefit of patients, including like what we saw in Minnesota, which is a certain increased level of reporting requirements about uses of 340B dollars. Now, I want to point out one more thing before I wrap up, is that Senator Bill Cassidy, I'm sure Darbin will get into this some too, but the Senator Bill Cassidy at the federal level, he chairs the Help Committee in the Senate, released a report last week on 340B. He had asked several entities within the supply chain and the stakeholders there, how are you using 340B? What's your interaction and relationship with that? Like, what are you doing? And one of those questions was to hospital entities, wherein they said, hey, how are you using your 340B revenue and distinguishing that from things like executive compensation and capital improvements and things like that versus charity care, to which that entity responded, revenue is revenue. This is not revenue. These are dollars. It's $66 billion just this last year that is supposed to be serving patient interest and need. This is not just revenue that you can kind of fluidly use. And so that is our position, that is our interest, and we certainly encourage patients to continue to advocate for their interests, whether in the states or federally. Thank you.
Thank you so much, Jen. You are a very passionate advocate with a lot of knowledge about 340B and how it affects people. And some of the information that you presented, the revenue, the $66 billion, where's it all going? How's it all being spent? Is it going to patient care? So I'll talk more about that as we move forward, but go ahead. Did you want to say something?
Think about this. How many headlines can we stop of somebody dying from lack of access to their insulin or their EpiPens or anything else for that matter? If that $66 billion was being used directly to reduce cost of these high cost medications, right? Like from patient pocket, that's the whole thing. I'm so sorry. Reverend Williams is astounding and y'all should totally get her on.
No, we'll have plenty of time to answer questions and talk more. But I am so excited to have Reverend Kimberly Williams today, who's going to speak to the understandings and perspectives surrounding the 340B and the communities that choose Healthy Life serves and the importance of the 340B reform to achieve health equity. So there you are, Reverend Williams. Go ahead and take it away. Thank you so much for being here.
Thank you, Liz, and good afternoon, everyone, and thank you to CCPA. It is a pleasure to be on. And at the community level, I'm the executive director of Choose Healthy Life, where we, in a unique way, marry faith and science. And so our work is really focused on what I would call a human-centered approach. And so our organization really emphasizes the human impact of these health policies. And so the 340B program was initially designed to help the vulnerable, as was stated before, and help them gain access to these medicines. But the current implementation of that has been impacted because the benefits are going more towards the hospitals and the pharmacies, as opposed to the local community that really needs it. So in our work, we position our community health workers within our churches, which is the oldest and most trusted institution in the Black community. And what we've observed is major discrepancies between what the real intent of this program was for and its real life effects. And so the access allows us to see firsthand that there are many struggles that the underserved community has seen, and it impacts their medications and the health services that they deserve. And so the impact on the community around this, for instance, the tax-exempt hospitals and pharmacies, they've turned this into a profit, right? As opposed to care, extending those resources in such a way that a grandmother can get what she needs by way of her medications, her services, et cetera. And those discounted meds then are not provided in the way that was expected. There's been some economic disparities. Statistics show that the hospitals are generating more than 8.5 times the spend on their care. And so these kind of economic disparities really highlight the need for the reform in the community where we're dealing with, I will say, you're dealing with the moms, the dads, the grandparents, all of the relatives in these intergenerational homes. And so what should have happened, where the benefits should have been in place to serve and meet those gaps, it's really becoming more of a revenue stream for what we already know are wealthy institutions, right? And then last but not least, the social determinants of health, where this access should have been able to help in those ways, it goes beyond just the access to medication. And so it encompasses broader social determinants of health, which our health navigators address through the community wellness. The failure of this program really exacerbates the existing inequities, and it makes it harder for more of our organizations to be able to help and fulfill the mission that we have when we're then having to make up for those challenges. One of the things that I want to highlight, and Jen mentioned it, you know, Senator Cassidy's recent investigation into this really highlights the bipartisan concerns over the lack of transparency and accountability within the system. And so even the findings from that really emphasizes the need for the reform of this policy to ensure that the program can fulfill its original mission. I think we got to get back to the drawing board, right? The initial mission was to serve low income and uninsured patients. And so this bipartisan effort, I think we need to really support getting back to its original intent and advocate to promote greater oversight and redirect those resources to benefit the underserved communities. I think the other piece, based upon our work within the community through our health navigators, we advocate for thoughtful reform when it comes to this particular program, that we realign it, that we really make sure we're supporting those low-income patients, and then that it includes ensuring compliance and reducing the exploitation of the program by large healthcare providers and pharmacists. And we are also urging our legislatures to consider the lived experiences of the community members. I think more of those real life stories need to be introduced into the conversation. You really don't understand until you hear the voice of those who are impacted. And so highlighting that and sharing those stories more often, we believe will also impact that. So effective reform really should prioritize well-being and ensuring that the resources reach those who are most in need. So on that front line, you know, we're seeing those challenges of people having those gaps that this program was supposed to help address. I think we're really seeing that the impact is causing greater gaps, and the reform is definitely needed. But I think it will be very impactful to get more of these lived experiences in front of folks so that they understand those real life challenges. Thank you, Liz.
Thank you, Reverend Williams. Very compelling, and you know, you're so right on. The patient's voice, the family voice is so important. And those are the voices that our congressional representatives and our state legislators and the opinion leaders need to hear.
Yes.
Sometimes it's hard to find those voices. So I'm going to come back to you in a little bit on how you do that, how you find those voices. So that may be one of my first questions to you. But thank you so much. I mean, in many ways, we lose our direction when we don't keep the focus on the patient, and we don't keep the patient in the center of what it is we're trying to accomplish, because it's a win-win for everybody when we do that. So I really appreciated the things you said. You really I've taken lots of notes already, and I'm sure I'm going to come back and have a lot more questions for you. Also, take a look at the chat, because things are coming up into the chat as we're moving through our different speakers. The Cassidy release of the report is there. The CANN 340B Action Center, Pioneer Institute, all really great resources. So we want to be sure that you get those and that you're able to spend some time looking at following these links and getting more information, because education is the key. Darbin, I was so excited to have you. You are the last panelist today, but not the least panelist. You're very important to be here. And so I'm going to turn it over to you. You're going to be discussing federal policy proposals to reform the 340B program and opportunities, which I think is really key for advocacy around these efforts. So it's all yours. Thank you.
Thank you, Liz. And thank you everyone for being here today and for the CCPA for having me. So I'm going to briefly touch on the various proposals introduced in the last Congress that would have an impact on the 340B program and the problems they seek to address. So last Congress, there were several major proposals introduced to reform the 340B program, each aiming to address gaps in transparency for hospitals, patient benefits, and strengthen oversight. One of the most comprehensive of these bills was the 340B Access Act, which was introduced by 3 House Republicans. The bill sought to address concerns that 340B hospitals were not sufficiently helping low-income patients. It would require hospitals to provide charity care based on patient income. It would ban aggressive medical debt collection practices, which hospitals shockingly are going after patients for medical debt. It's also targeting the lack of transparency and oversight by proposing new reporting requirements and program integrity measures across the program. And finally, it aimed to regulate the use of contract pharmacies, which, as some of the other panelists have discussed, have fueled concerns about program abuse and expansion beyond the program's original intent. The second major effort came from a bipartisan working group of 6 senators, which released a discussion draft last year. Their proposal also focused on strengthening transparency, tightening program integrity rules, better regulating contract pharmacy arrangements, addressing many of the same problems identified in the 340B Access Act, but in a more in a slimmer way. In addition, there were 2 smaller pieces of legislation introduced that reflect some of the reforms we're seeing in the states. The first is the Protect 340B Act, which bans discrimination by pharmacy benefit managers or PBMs, health plans, employers, and others against 340B providers seeking to protect providers' access to discounts and pharmacy arrangements. The second is the 340B Patients Act, which codifies the use of unlimited contract pharmacies by 340B covered entities, a policy that's been in place since 2010 and has been one of the main reasons we've seen exponential growth in 340B. Separately, some good news, the House Energy and Commerce Committee did advance a piece of legislation, the 340B Transparency Act. This bill sought to address the lack of public information about how 340B hospitals were using their savings and it would have also required basic reporting on patient demographics, charity care levels, and the use of their 340B revenues. And although the committee approved it, it unfortunately did not make it further than that. Altogether, these proposals show a growing bipartisan interest in improving the 340B program through transparency and ensuring patients benefit. Now, looking ahead to the 119th Congress over the next 2 years, there's a lot of momentum for these major reforms to the program, as we saw from last year, with a strong focus on improving patient affordability, transparency, and ensuring program dollars are being used as intended. On the House side, Congressman Buddy Carter, a lead sponsor of the 340B Access Act, now chairs the House Energy and Commerce Health Subcommittee. I'm hopeful that he'll reintroduce the legislation to ensure prescription drugs are more affordable for patients and increasing transparency. In the Senate, the bipartisan working group is expanding, with Senators Tim Kaine, John Hickenlooper, and Markwayne Mullin joining the effort. After releasing a discussion draft last year, the group is likely to pursue a full bipartisan bill this Congress, hopefully aimed at tightening patient program oversight and ensuring savings are being passed along to vulnerable patients. Importantly, leadership changes would also work to accelerate reform. Senator John Thune, who was a member of the 340B working group, is now the Senate Majority Leader, increasing the odds that 340B legislation will be prioritized. Additionally, as some folks mentioned, Senator Bill Cassidy, the new chairman of the Senate Help Committee, is reported to be working on a 340B reform bill following his investigation into hospital revenues, which came out last Thursday. I expect that this possible legislation that will focus on requiring hospitals to disclose how they're using 340B savings, looking into contract pharmacy practices, and making sure the program is delivering direct benefits to patients rather than padding hospital profits. Taken together, these expected proposals share an overarching goals to restore the original intent of the 340B program, protecting vulnerable patient populations like working families and those in rural communities, increasing transparency for patients and taxpayers, and cracking down on abuses that divert resources away from those who need it most. If you care about any of these reforms to make drugs more affordable and make sure hospitals are doing right by the 340B program, the best thing you can do is get involved at both the state and federal levels. Reach out to your elected officials, share your stories, and push for changes that make sure hospitals are providing affordable drugs to patients and not going after them for unpaid medical debt.
Darbin, thank you. We've heard a lot of passion from everyone and a lot of concern. What I've heard throughout everyone's presentations, the word gaps, the word transparency, the words misuse. So I want to go back to Bill real quick and just say, for a patient, how do I know if I'm a 340B patient?
Well, you can ask, but one thing you can do is go on the Pioneer Institute website. We list all the 340B covered entities, hospitals, and clinics, and you can look up in your geographic area and see whether you're actually a patient at a 340B facility.
So in that realm, so let's say a patient is going to their pharmacy. Let's talk a little bit about the difference between contract pharmacies and individual pharmacies, individual owned independent pharmacies in the rural areas. We're seeing a lot happen to them. They're disappearing, very alarming. I remember we've been through the Policy Alliance and through the Chronic Care Coalition, we have been a huge proponent of utilizing pharmacists as part of the care team and making sure that we're doing the right meds, right time, and not having interactions and all of that. And we saw a real movement, especially with independents, where they were doing what they were supposed to be doing, what they were intended to do at the top of their license. Now I'm starting to see a decline, and we're hearing from our pharmacies that they're going out of business, that they're not getting reimbursed, and that the contract pharmacies are getting, paid back for the medicines that they're using, and the independents are not. And I'm just really concerned on how do we help get the information out. And one of the things we have done through the Policy Alliance is we have done ads all over the country, many states, and the ads are targeted more at education and reform and sending them somewhere to like our website. And like I said, all of you have amazing links to get more information. How do we best engage the patient's voice? How do we see what is happening in the community and Jen, maybe you can answer. You and Reverend Williams can both, take a look at that and answer that, because you're working at the community level and you're seeing the things that are happening, and you're seeing things when they're done right, and you're seeing things when they're not done right. So how do we get that patient voice? How do we bring it to the forefront so it's louder and stronger?
I love this question. We also have a question in the chat here about with the aggressive actions of the current administration, will the program go away? I don't think it will. I just want to be real direct on that. It's a super straightforward answer. I don't think the program goes away. Indeed, on the executive order about prescription drug prices, there is reference to the 340B program, both explicitly and not explicitly. That is an intention that the program is still going to be there, right? So I don't think there's an effort to get rid of it. But in terms of involving patient voice, every time that I engage any patient community around me or anything else about 340B, the first thing I do is talk about how much money is in that, and everybody turns around and goes, but where's mine? It's not hard at that point in time, as patients struggle for access to care, to go, hey, like, this really sucks. What do I need to do? Who do I need to yell at? Especially if somebody wants to call a manager about it. Unlike your legislators are the managers about that, right? This is how you can engage. It is not different from engaging on any other legislative issue that's in front of you. It's knowing how this complex system works, and it is intentionally complex to make it challenging for patient voice to be inserted. I remain steadfast that the only way you're going to find patient-oriented solutions is with patients driving those solutions. I think Reverend Williams can probably talk a little bit more about her activation as well.
So Reverend Williams.
Thank you for that. I think one of the most important things, and this is where I believe our community health workers are essential, is that they are feet on the ground. And what I like to say is they really disciple the community and those who are getting care through these different systems and the lack of what was supposed to be in place to help and support them through the system. So when you ask the question, how do we do a better job at, I would say, capturing the voices of our patients? I think it's essential that we tap into our community health workers because they are doing that work day in and day out and really making the contact to help community members navigate through 340B, getting to the end of getting to their medications, all of those different things that are important and essential to our healthcare system. I think the other thing that's essential for our communities is that we're providing a level of literacy around 340B that helps the community even understand what they're navigating. I appreciated what I think it was Bill said, Dr. Smith said up front, the importance of going to the website, but sometimes we provide information on websites that the community can't digest. And so I think it's important that when we send them to these resources, we consider who's really using it and does it meet the need for them to be able to get a great understanding and then know how to access and implement the tools to help them through. And that's what's so key about our community health workers, right? That they become their advocates, if you will, to help them with those questions, help them understand maybe the scripts to use with their own doctors. Am I a 340B patient? That's a great question. But then if they don't know how to follow that question up with the next question. So I think the role playing that our health navigators do with the community members is also very, very essential. I think what I'll end with here is I was listening to an interview of Toni Morrison, the great poet. And what she lifted up is that someone had told her she was, chaos was happening in the world. And in her mind, it was time to rest and really let her writing go She said that the mentor told her, in chaos, that's when your work is most necessary and needed. And so in this time where we are really looking at the need for reform, this panel, the work that everybody on this particular panel is doing, we gotta put a full court press. I'm a basketball mom, all hands on deck, and get louder, be more intentional, and really help to escalate the need for the reform. A reform that's going to definitely help us to have that transparency and accountability. We've got to continue to push for the policies that help to really direct more program funds towards communities and our health initiatives. We have to continue to advocate for updated eligibility criteria. I think it is also necessary so that we ensure that the smaller community-based clinics receive the adequate support. We have to really stress the importance of tracking and reporting the outcomes. Again, that happens with our community health workers to demonstrate the program's real impact on the underserved populations. And then have a balance where we'll share those gaps and those stories that we find the barriers and the challenges. I think we need to balance and share some of the successes, and then study what has helped us to see that great success. Last but not least, collaboration, which is what this panel brings to the table, making sure we do it together, not alone.
We're always better together. No, thank you. Those were really, really great points. And I love when you're talking about we must, have a full court press. And, I think all of us stakeholders and advocates, we run into the fire. We get it. We're there. We're not afraid to run in the fire. We have to somehow make people less fearful when they share their voice. That nothing is going to happen to them, because there's a lot of fear, I think, and mistrust is okay. If we come forward and we start talking about it, what's going to happen to me? Should I do it? Should I not do it? And I think you addressed it beautifully. So thank you for that so much. I'm going to come back. Darbin, I think, when you're talking about federal reform, and there's a lot of legislation going on in the states all over the country. Can you address, do you think it's more important to have federal policy first, or how does it relate between federal policy and state policy that's going on?
Yeah, absolutely. I think traditionally, when it comes to a lot of changes we see in the healthcare system, traditionally a lot of states end up going first and be sort of a benchmark or inspiration for federal action. I wouldn't say that federal reform is more important than state reform, but 340B at the end of the day is a federal program. And ultimately, there are limits to what the states can do on 340B, but that doesn't mean we can't make progress. As I said, states are often where policy begins in order to try out new ideas and see if they could work at the federal level. And as those states make progress, that can embolden federal lawmakers from those states to become champions and support meaningful reforms. And as I noted, it's incredibly important to reach out to your elected officials, both at the state and federal level, on these issues. So that way they both know what's going on with the program and you can be engaged.
So we just got a question that I think is really timely in what you're talking about. When speaking to legislators on a state level, what is the argument against this type of legislation?
I think, as was noted to hospital statements in Senator Cassidy's investigation in the Help Committee, hospitals will often argue that they need this revenue in order to cover their operating costs. But of course, there's a lot of wealthy hospitals out there that are benefiting exponentially from the program. So I think there needs to be a clear contrast between what I would call have and have not hospitals. Hospitals that are clearly doing the work, providing the charity care for patients, and those hospitals should be inspiration to make hospitals throughout the program act better. Same with federal grantees. Federal grantees often will do what is intended with the 340B program in a much better way. So there's no reason that a big hospital chain can't do the same.
Well, and I would like to point out that hospital operating costs aren't always charitably oriented, right? So if you're paying a private equity firm for management services and they're exponentially charging more, or you're paying a staffing firm rather than paying your providers or your care staff directly, those are not necessities within the cost baseline of a hospital. And those are things that we've got to consider. There are ways that hospitals can manipulate their operating bottom line to justify saying, we don't have margins.
And a great example of something that is not care oriented within hospital revenues is spending $8 million on a nationwide Super Bowl ad, as NYU Langone did earlier this year.
Well, that was money well spent, wasn't it? It comes back again, patient-centric. It's got to be patient-centric. Everybody needs to be following that because, I mean, isn't the end game the goal? Whatever you're hitting the hoop, getting the ball through the hoop, making that score, getting that goal. Isn't it we all do better when people are feeling better, that the quality of their healthcare is better, that when they get access to care, they're better, instead of getting sick care or getting sicker care or getting denied access to care or not knowing about programs that would serve them better. And so I think one of the things that has really interested me, and I you know, the Chronic Care Policy Alliance, we and the Chronic Care Coalition, we had some big discussions about, you know, legislation, and we had a proposition here last year, was Proposition 34. We actually went on to support that proposition, which included transparency, and 98% of the funding or the money had to go into patient care. And if it wasn't and was looked at and checking the data, someone could lose their license from being a 3040B provider for 10 years. And so, you know, then we look at legislation and everybody's like, yeah. We want to do this legislation. And I was in the hearing last week. And when we came out with an opposed position, we said, why do we want to expand a program that isn't transparent? We don't know how the money's being spent because we're just going to do a letter of concern. And finally we said, no, we're not going to do a letter of concern. We're going to do a letter to oppose the bill because the bill isn't going to help anybody the way it should. It's going to expand the program. It's going to cost more money, and the benefits aren't going to change because nobody's being transparent about it. And so, but here's what's hard, and maybe you guys can answer this in the next couple of minutes because I know we're going to run out of time. How do we engage the advocacy organizations to sign on to letters or in their states or join other states to oppose some of this legislation that's happening that isn't good for the state, but it sounds good because the state budgets are hurting. California state budget is really hurting. This is a great way. Let's expand the program. And that resonated in the hearing. Oh yeah, let's expand the program because the state is short on money. So here's a way we can get more money to do what it is that we need to do, but we're not going to really tell you what it is that we're doing because we don't have to be transparent about it. So I'll throw this out to all of you. Anybody want to take that one on?
Reverend Williams, I see you off mic and so am I, so it's up to you.
I'll let you take the lead. I think we're going to say some of the same things. So go right ahead. Go ahead.
Yes, ma'am. We can break our silos down, right? Like in the HIV space, we're quite used to working with other HIV advocates. We don't get a lot out of that space. We like to do what we're good at, right? I think we've got to get uncomfortable. We've got to start approaching people who look different from us, who have different health conditions and different experiences from us. We need to look for opportunities where we can go, hey, Yep, I'm going to an arthritis conference today. That's not my space, but I'm really interested in what's going on for them. And I think that we've got some industry opportunities with our trade partners, like the trade organizations, Pharma and Bio, with their patient-oriented outreach to say, hey, how can you help us connect, right? Let's reach folks in spaces that we don't know a whole lot about. You got a panel of experts, and I mean experts. We like being experts. Our egos are well served by being the experts, but we need to be a little humble as we approach other folks and ask them questions about what's important to them, and then maybe introduce some ideas about what's important to us.
Well said.
Mhm.
We only have a couple minutes left. I don't see any other questions in the Q&A box. Be sure to send them in if you have questions that didn't get answered today. Please go ahead and send them in. One of the things I wanted to tell you is that the Chronic Care Policy Alliance did an explainer video. I know others have also done that. So please go to our website. I think we've got it coming up right now. It's Chronic Care Policy Alliance 340B, helping patients or padding profits. It's a very simple explainer video that really gets into simplifying what the 340B program is. And feel free to utilize it, share it, do, put it out on social, however you want to get the word out. Because I think it's really important to add that piece of legislation. I want to thank you all. My goodness, we could talk about this for a lot longer than an hour. I'm getting to think hour-long webinars aren't long enough, but there's a lot of them, so we just have to do more. But I want to express our big thank you to all of our guest speakers and the audience for joining us today. We hope you found today's conversation educational and informative. I hope it leaves you asking questions that we might be able to do better in helping give you the answers. We want to all work together. We are better together. So I think that resonated really well with what everybody said today. So thank you, Bill Smith, Darbin, Wofford, Kimberly Williams, Reverend Williams, and Jen Laws for your expertise in this field and for your passion, because that was what we saw that passion come out of you, and for being such great stakeholders and leading the charge on a really difficult conversation. That it's difficult in many cases to have this conversation with other stakeholders, with hospitals, with different entities, and at best doing it with our legislators and our representatives, which is where real change will happen. So thank you all. Thank everyone for joining us today. We are right at 1 o'clock in California and 4 o'clock your time if you're on the East Coast. So again, thank you so much, and we will get back and talk to you soon. Thank you so much.